Thank you very much, and thank you for your kind invitation. My apologies that I cannot do the presentation in Hebrew. And I want to congratulate you on the great success of your ACCESS program. So this is my first slide, and I want to report on what's been happening in the UK. These are my declarations. I don't have any conflicts with regard to this presentation. It's very interesting that if we look at age-standardized mortality in different countries around the world, some of the traditional areas in Western Europe and elsewhere appear with a much lower rate than has been seen in the age-standardized rates in Africa and parts of Eastern Europe and Russia. In the United Kingdom, we've had a bad reputation. We've had a bad reputation of having a high death rate from ischemic heart disease, but it has changed remarkably. As you see from this curve, this is the comprehensive deaths from cardiovascular disease in the whole country. I report a little bit about the International GRACE program, which is in 14 countries and comprises more than 100,000 patients. The interesting information here is that although the early death rates in the first 15 days are higher after ST elevation infarction, in the follow-up phase, the death rates are higher after ST depression presentation. And this is even after adjustment for all the baseline confounders and the baseline risk characteristics. The hazard ratio is still 1.3, an excess risk for those with ST depression versus ST elevation. And as you've seen in your own ACCESS registry, there's been a change in therapies over the course of time, and our GRACE program went over 10 years. I also show for comparison information from the EuroHeart survey, and this is the information on the various treatments which have changed between 2000 and 2004. And these are the rates of angiography, PCI, and CABG in the EuroHeart surveys of that time. Please note that the EuroHeart survey is a voluntary survey, and the median age was 66. I think the median age in your ACCESS program is 64. This is an issue, and we will perhaps come to that, because if you have entirely comprehensive data, the age is older and there are more women. Interestingly, in the course of time, these are the trends in deaths from our GRACE program, and the rates of major bleeding, in fact, despite more aggressive therapy, have declined. I'm now going to report on the United Kingdom MINAP program, which is the myocardial ischemia project. It is funded by the government. It involves every patient admitted to every hospital in England and Wales. It's not voluntary in that if the hospital doesn't report the patient, they don't get reimbursed. So there's a pretty strong incentive to be involved. Please note that there are more than 750,000 records since 1998, and that there is feedback and audit in the program. In the interest of time, I'll not go into some of the other detail. So these are the number of non-ST elevation MIs per annum, and you can see that there are more than 40,000 per year. Please note that the median age is 74, not 64, 74, and please note that 38% are female, a rather higher percentage of females. This is hypertension and hyperlipidemia, as you'd expect. These are the antiplatelet and statin treatment following presentation, so really quite high treatments with thienopyridine, a statin, and aspirin over the course of time. And just as you've seen in your ACCESS program for the thienopyridines increasing over time. And here are ACE inhibitors and beta blockers, similarly, a trend which is significant for increasing over time. Here is the rate of angiography. Now, in the past, angiography rates had been low in the UK. You can see that they have progressively increased. And this obviously includes all patients in every hospital. And this is PCI and CABG, and here are the rates of about 54% for all patients, and CABG about 10%. So this is all MIs. This is from the report of 2010. Non-ST elevation MI constitutes the majority, just as in your program, 60% on non-ST elevation MI, 40% are ST elevation, 38% female. This is primary PCI, which is the dominant therapy, and this is the proportion of people who are treated within 90 minutes for everybody. And you can see it's 88%. We have a quality control program so that published there are the information from every single center on the web about the time delays, so that you can see these are the time delays for every center, and they are plotted. For comparison, here are the data from the EuroHeart surveys, and the timely reperfusion rate was 69% within that program. There are still patients who receive thrombolysis, and this is the call, the patient's call to needle time of less than 60 minutes, achieved in about 3/4 of the patients. Just as you have, there's been an increase in the use of secondary prevention in all of these patients, and you can see the progressive rise in ACE inhibitors, ARBs, aspirin, beta blockers, thienopyridines, and statins. Gratifyingly, there's been a remarkable decline in 30-day mortality. And this is a 33% decline in 30-day mortality in the course of 7 years. There's similarly been a remarkable decline in non-ST elevation MI 30-day mortality. And this is the 6-month mortality, which has also come down. So my conclusions are that there have been temporal changes, just as you have seen in the ACCESS program, in both pharmacological and interventional treatments. There is a high degree of compliance with secondary prevention. There's been a progressive decline in in-hospital and post-discharge mortality. Please note that the data are strongly age and gender dependent, and that we have scope for further improvement. Thank you very much.